So I want to welcome you to the second session today. Good afternoon, good morning, good evening to wherever you are in the world. My name is Dekker. I'm a member of the Scientific Review Committee of the LRI. By profession, I'm a rehabilitation physician. Now you know a little bit about me. I want to welcome you to this session on post-exposure prophylaxis. We have two big presentations on very huge studies. We have two small presentations, pitches. The big presentations will take 8 minutes in presenting and have 6 minutes for questions asking. The pitches will last for 3 minutes and have 1 minute for questions. So I hope the system is clear. In order to have as much time as possible, I'd like to introduce you to Dr. Ephrem Mamo. He works on Addis Ababa University and he is involved in the PEP4LEP study. His presentation is about chemoprophylaxis for leprosy, comparing the effectiveness and feasibility of a skin camp intervention to a health center-based intervention. The floor is yours.
Thank you, Dr. Jose. Can I start?
Yes, please go ahead.
Yeah, thank you. I'm going to present the preliminary findings of chemoprophylaxis for leprosy. It is comparing the effectiveness and the feasibility of the two interventions. One is the skin camp intervention and the other one is the health center-based intervention. It is an implementation trial in the 3 countries. When we see the context of the research project, single-dose rifampicin has a proven efficacy as a post-exposure prophylaxis with a 57 risk reduction when it is given to leprosy patient contacts. And the effectiveness of this single-dose rifampicin for contact of leprosy patient has been established and included in WHO guidelines. The aim of this trial is to contribute to interrupt Mycobacterium leprae transmission by identifying the most effective and feasible method of integrating the skin screening of contact of leprosy patients, and when they are eligible, providing or administering the single-dose rifampicin as a chemoprophylaxis. The study is conducted in Ethiopia, Mozambique, and Tanzania. There are 4 objectives, 2 primary objectives and 2 secondary objectives. The 2 primary objectives one is to compare the effectiveness of the two intervention in terms of the rate of leprosy patient detected and the case detection delay. And the second primary objective is to compare the feasibility of the two interventions in terms of effectiveness and acceptability. There are also 2 secondary objectives. One is to assess the acceptability of integrated skin disease approach and the use of skin app, which is developed by NLR, and to assess the capacity of the health workers in diagnosing leprosy patients and other neglected common skin disease. When you see the study designs, it is a 12 cluster randomized implementation trial. Having the 2 groups. One group is intervention 1, which is a community skin camp on average of 100 close contacts. That means household contact plus neighbors of leprosy index patients will be invited to be screened, and when they are eligible, providing the single-dose rifampicin. And the second intervention is the center-based interventions. This is inviting of the household contact to the nearest health facility for screening, and when they are eligible, providing the single-dose rifampicin. For both interventions, we use an integrated or common skin disease approach in order to diagnose the common skin disease as well as anything with a skin lesion such as leprosy. Ethical clearance was the trial was registered and the ethical clearance was obtained from the 3 countries. As you can see from this figure, the study is conducted in Ethiopia, Mozambique, and Tanzania, and it has two groups: intervention one, that is a community-based screening and the providing of single-dose rifampicin. In this group, 19 index patients will be included for each country, and the 9,000 contacts will be screened, and when they are eligible, providing a single-dose rifampicin. The second intervention group is the health center-based intervention. In this group, 135 index patients will be included, and the 810 contact will be screened and provide single-dose rifampicin when they are eligible. So this is our target samples. Next, please. Then we see the preliminary finding that was from Ethiopia. The study was started, the data collection was started in 2021 in Ethiopia. And as you can see from the table, index patient included in intervention one is 22, and then intervention two is 23. And the contact screened is 1,924 in intervention one and 83 in intervention two. And from these contacts, those received single dose rifampicin is 87.5%, and the other, due to different reasons like pregnancy, age less than 2 years, will be excluded, given voucher. And as you can see from the table, the refusal rate is 0%, and the new leprosy patient diagnosed from the contact screen is 22, and from each averagely on one skin campus, one index patient will be diagnosed in this study, and with 1.1% of contacts are diagnosed with a new leprosy, for diagnosed leprosy patient, and the contact diagnosed with the skin disease is around 45.3 in skin count, and the intervention to 1.2%. Next. In Tanzania, the studies started in 2019, and the data is between 2019 up to 2021. Index patient included is 38 in intervention one and 91 in intervention two, and the contact risk screen is 4,142 in intervention one, and those received single dose rifampicin is 87.6% in intervention one, and refusal rate is 0, and with a new leprosy patient is diagnosed by Dekker study is 24, which is 0.6% in intervention one, and the contact diagnosed with the skin disease other than leprosy is 56.7% in intervention one and 26.7% in intervention. Next. The third country that was the study was conducted in Mozambique. It is started in 2021, and as you can see from the table, the study in intervention one, that means the skin count is not yet started in 2021. So due to different reasons like COVID-19 and the rifampicin import bureaucracy, the skin count intervention was not started in 2021. So currently the skin count intervention is conducted, started, and you can see from intervention to 19 index patient was included, 51 screened, and 50 or 98% received single dose rifampicin. About publication, and the pending two paper-led publication are published in Los MEPD, and the other three baseline surveys, which was the result was presented last year in the NLR spring meeting. It is ongoing to be published in Leprosy review soon. The skin up validation manuscript in preparation phase. Next. The strengths of this study: one is a combination of integrated skin screening and the providing of single dose rifampicin as a post-exposure prophylaxis will be according to the WHO guideline, which is important to reduce contacts of risk of developing leprosy. And the second strength is involving community leaders is very important. It is when we are organizing contact mobilization for site selection, like when we are selecting the school and the communities are, we involve these community leaders. It is also our strength. And also, as you can see from the preliminary finding, in most skin campus, averagely one new leprosy patient was detected or diagnosed, and also high number of skin diseases was diagnosed in the skin campus. And also, there is no refusal of taking of single dose rifampicin in the studies. As a limitation, one is because of the long incubation period of leprosy, the epidemiology of getting of the new case detection rate will not be sufficient time to detect. One is limitation with that, and the other one is due to the impact of COVID-19. There is a delay of starting the study, and also the physical distancing also affects the intervention one, that means the skin camp intervention, which needs gathering of 100 individuals in one site. So due to that, due to COVID-19, it is difficult to arrange the skin campus. And also PPE materials also increase the cost of the study. And also shortage of rifampicin, specifically in Mozambique, also another challenges. And also high transfers of trained health workers are also the challenge, which needs more refresher trainings. And also inaccessibility, like poor road infrastructures, heavy rains during conducting of the study, specifically the skin camp was difficult due to infrastructures and progress, and some skin diseases which needs oral medication. And this study has a protocol of providing only topical treatments. Due to that, some of the patients are referred to the nearest facility due to not providing with oral medication. These are some important challenge, limitation of the challenges. As a conclusion, more data is expected, but based on our available data, more number of skin diseases was diagnosed by skin camp or intervention one, and the active case finding and the raised awareness are important to detect more cases and improve early case detection, and also disability rate at the time of diagnosis. This study also hopefully translate a medical intervention into the routine case, providing of single dose rifampicin. Finally, I would like to thank our partners, our funders, and the study participants. Thank you.
Thank you, Dr. Mamo. We have a little bit more than 2 minutes left for discussion and questions. Are there any questions?
Yeah, thank you. So we have 4 questions. Let me start with one from Claire McIntosh. She's asking, what was the cost of the 2 activities? Were they the same? And obviously in the skin camps, you saw a much higher volume of people. So did you estimate the costs yet?
The cost effectiveness analysis or the cost effective study is going after the implementation of this study. Currently, we are conducting the 2 interventions parallelly, and still the cost effectiveness will be at the end of the study. So at this moment, it is difficult to estimate the 2 interventions cost.
Okay, thank you. And there are 2 questions from Peter and from Becky concerning the skin diseases. The question are, what are the common skin diseases you found? And did you found also skin diseases in leprosy patients, other skin diseases?
Yeah. Commonly, we diagnosed fungal infections like Tinea capitis is the most common one in Ethiopia that was diagnosed by the dermatologist. Commonly is the fungal infection, the Tinea capitis, Tinea corporis, and also other common scabies, but scabies also another. We ranked top 10 common diagnosed skin diseases, but commonly it is the fungal infections. That is why, for example, the Tinea capitis, it needs glucophobin oral medications. So majority of them are diagnosed with the Tinea capitis, and we have a difficulty of getting the glucophobin oral medications.
Okay, thank you very much. I'm afraid we have to wrap up this presentation.
Yeah, maybe we can discuss the rest of the questions at the end of the session.
Yeah. I want to thank you very much, Dr. Ephrem Mamo, for your excellent presentation. I want to continue with another representative of a big study in the Comoros and Madagascar, also on post-exposure prophylaxis. It's presented by Dr. Epco Hasker from the Institute of Tropical Medicine in Belgium. The floor is yours, Epco.
So yes, good afternoon. So I would like to present a brief update on the ongoing people trial on post-exposure prophylaxis on the Comoros and Madagascar. So the trial is implemented on 2 islands of the Comoros, Anjouan and Moheli, and in Miandrifaso district of Madagascar. The intended sample size was 144,000, 36,000 in each of 4 study arms. And this was based on an expected annual incidence of leprosy in the comparator arm of 1.4 per thousand, and a 50% reduction in each of the intervention arms over a 3-year study period. So there are 4 study arms. PEP is provided as a single dose rifampicin, but at 20 milligram per kilogram, so double the regular dose. That's why we call it single double dose rifampicin PEP, or SDDR PEP. Arm 1 is the comparator arm, in which we conduct annual door-to-door screening for leprosy. Patients identified are treated, but no prophylaxis is provided. In arm 2, we also do annual door-to-door screening and treat leprosy patients. But in addition, we provide rifampicin to all household contacts of index cases. In arm 3, we do the same as in arm 2, but rifampicin is provided not only to household contacts, but to anyone residing within 100 meters of an index case. And if more than 50% of the village population is eligible, we'll cover the entire village with PEP. In arm 4, we do the same as in arm 2, with PEP provided to household contacts, but we also do a serological test, anti-PGL1, and anyone living within 100 meters of an index case and testing positive to anti-PGL1 is also given PEP. Randomization is at village level. During door-to-door screening, we use an Android app on smartphones to record data and also geographic coordinates of households visited. That allows us to do spatial analyses. In addition, skin samples are collected, on which Bauke presented earlier in another session, for molecular biology. Now, the main analysis is incidence of leprosy over the 3-year follow-up period by study arm. And as I said, randomization is by village. So we have 4 arms, and villages are randomized to one of the 4 arms. We compare arm 1, the non-intervention arm, to each of the 3 intervention arms. What we measure is not the individual effect of PEP, as was done in the CoLab trial, but rather the potential of PEP to reduce incidence at village level. We also look at spatial clustering of leprosy to get an additional impression of where best to target control measures such as active case finding and PEP. And we also look at phylogenetic clustering to further answer the question on how best to target. Door-to-door screening started in January 2019, and we are now in the third and final year of follow-up. To date, we have recorded over 107,000 participants. During the baseline survey in 2019, we recorded 455 cases, equivalent to an overall prevalence of 4.5 per 1,000. Prevalence was highest on Anjouan, Comoros, with 6.0 per 1,000. On Moheli, Comoros, it was 1.8 per 1,000. And in Miandrifaso, Madagascar, we found a prevalence of 3.1 per 1,000. And as you can see from the graph in this slide, the baseline prevalence in 2019 was much higher than the annual incidences found in year 2 and 3. And there was a bit of an imbalance at the baseline, with arm 3 having the highest baseline prevalence. And that's because randomization was based on reported incidents in the 5-year period preceding the study. In year 2, you see a sharp drop, especially in arm 3. But during year 3, you see an increase again in all 4 arms. Now, the highest baseline prevalence and subsequent incidence was found on Anjouan, Comoros, where over 55% of the study population, approximately 60,000 people, and 76% of cases at baseline reside. And as you can see on Anjouan, we saw a clear increase again in incidence from year 2 to year 3, up from 87 cases in 2020 to 143 in 2021, but across all the arms. Now, it needs to be stressed that these figures are preliminary and do not take into account the actual follow-up time. We have recorded all cases, even those not enrolled in the study yet at time of diagnosis. On Moheli, we saw the lowest baseline prevalence and a clear reduction in incidence over the first 2 years of follow-up, but the numbers are small: 38 at baseline, 12 in 2020, 4 in 2021, on a population of approximately 24,000. Then in Miandrifaso district, Madagascar, we found a baseline prevalence of 71 on a population of approximately 21,000. The following years, there was a steep drop across all arms. 9 cases were detected in 2020 and only 3 in 2021. Now, this is a slide that I've also shown last year on the association between the distance to the nearest prevalent leprosy case at baseline and the probability of being diagnosed with leprosy for each individual. The reference category were those living at 100 meters or more from the nearest other person with leprosy. As you can see, we observed a clear gradient. Just over half the population live at more than 100 meters of the nearest index case, and among them 0.2% had leprosy. About 2% of the population were household contacts of a leprosy patient. In this group, 3.4% had leprosy. And taken into account contextual confounding, the random effects model shows a risk ratio of 7.5 per household contacts, a clear gradient among neighbors within 25 meters. Still, the risk was 2 to 3 times higher than those living at 100 meters or beyond. And in this slide, you can see the same association, but now for incident cases. The risk of being diagnosed with leprosy in 2020 as a function of the distance to the nearest index case at baseline in 2019. We controlled for provision of PEP because due to the design of the study, PEP provision is strongly linked to distance from index case. The individual effect of PEP was a 74% reduction in risk, but that does not take into account whether subjects were enrolled in the study at time of diagnosis, neither time of follow-up. So that is very preliminary. It was just used here to control for confounding. The important result here is the spatial association. And again, we can see a clear gradient with household contacts at much higher risk, but also neighbors within 25 meters, still more than 5 times more risk than those who live at 100 meters or beyond of the nearest index case. About distribution of PEP, this had started in the Comoros in 2019, in Madagascar only at the time of the second survey round in 2020. So far, over 24,000 persons received PEP. PEP was well accepted, but in arm 3, the blanket arm, we see increasing proportions of refusal. Still, even in arm 3, approximately 90% accepted PEP. We did only passive monitoring of adverse events, but the teams were present in the villages for several days and no adverse events were reported. So we are now in the final year of the people trial. The final survey round is ongoing. Despite the COVID pandemic, implementation has proceeded as planned. Intake has been lower than expected, probably due to inaccurate population estimates at baseline. We found a high baseline prevalence, in particular on Anjouan and in Madagascar. Incidence, however, was low, both in Madagascar and Mohéli, but high on Anjouan. On Anjouan, incidence appeared to have increased again during the second year of follow-up across all 4 study arms. And though there appears to be a protective effect at individual level of PEP, we do not see much of such an effect yet at population level. But as I said earlier, the study is still ongoing, and the graphs I showed earlier do not take into account differences in follow-up time. And also we have seen that at baseline, the prevalence was highest in arm 3, the blanket coverage arm, so there was a bit of an imbalance there. And clustering beyond household level was clear at baseline, and again, when looking at incident cases in 2020. Now, during the remainder of this year, we will complete the final survey round. No further PEP will be distributed this year. We hope to have completed data cleaning and locked our database by March 2023, after which we will then conduct our final analysis. And then finally, I want to acknowledge our partners and funders. And in particular, I want to acknowledge the staff of the National Leprosy Control Programs of Comoros and Madagascar, and their implementing partners, Damien Foundation and Fondation Rolfo Lero, for all the hard work they've done and for making this project a success. Thank you.
Thank you very much, Epco, for this clear presentation. There's time, about 2.5 minutes for some questions.
Okay, up to now, Joss, I'm afraid we don't have questions.
But in this case, I might start with one. We saw with PEP in Ethiopia, there was no refusal whatsoever to use PEP. In your study, you see up climbing refusal during the years. Do you have any explanation for that?
Yeah, the refusals, there were not that many, but mostly it was in arm 3, the blanket arm. So I can imagine that if we cover a whole village basically, and that if you're the household member of a leprosy patient, you will be happy to take rifampicin. But if you're a distant neighbor, perhaps you'll be less interested.
Okay.
We have, meanwhile, one question from Becky Rivera. How did COVID impact your results from preventive measures like social distancing and masks?
Yeah, the impact of COVID on the study itself has been really limited. There has been a lockdown on Mohéli for 2 months. In Madagascar, they have not been able to go into the field for a couple of months, but still they have managed each year to screen the entire population. Of course, we took a few preventive measures, wearing of masks, for instance. And it is not a camp approach, it's door-to-door screening, so you don't gather a lot of people. And in addition, we have even added on a small study looking at COVID as a sentinel study in hospitals, among hospital staff. But yeah, unfortunately, when COVID did arrive, it came very sudden and it was there all over Moili before any warning sign became apparent.
Okay, thank you.
Okay, thank you very much. We wrap it up at this moment in order to save a little time in the end for questions for all four presenters. Epco, thank you very much for a very clear and nice presentation. The next presentation will be done by Dr. Samarul Islam, also on post-exposure prophylaxis, testing app-supported delivery system for leprosy web services. The floor is yours.
Respected chair and co-chair and other presenters and audiences, a very good afternoon to everyone. This is Samarul Islam from NLR India. I will be presenting on our research project, testing an app supported delivery for leprosy post-exposure prophylaxis services in India. And we greatly acknowledge the generous funding from St. Francis Leprosy Guild and Leprosy Research Institute. Next slide, please. So India is one of the largest, highest global leprosy burden and yet to control leprosy incidence. And research and that single dose rifampicin post-exposure prophylaxis can be successful in reducing the number of new contact cases if it is given to the close contacts. And NLR India is tested the feasibility of implementing SDR PEP, and it is now being implemented as a national level program since October 2018. However, the implementation has been scattered and incomplete with major gaps in contact listing and scheme provisions. Therefore, there are a number of possible barriers. It's like contact tracing and listing, contact screening through multiple inclusion and exclusion criteria, as well as administration of SDR PEP to the eligible contacts. And it's also involved manual cumbersome purchase and stock keeping of rifampicin. Therefore, next slide, please. Therefore, the NLR India proposes to strengthen the single dose rifampicin post-exposure prophylaxis program in the country by developing an app and testing it through clustered randomized control trial by answering the question of to what extent is a mobile application assisted SDR PEP delivery system more successful and practical than the current paper-based method. So this program will be implemented in 2 districts, the lowest administrative division of Indian country, that is in Paschim Bardhaman and Howrah district of West Bengal province in India. And this study will be carried out over the period of 33 months, and the project is started in August 2021. This study will be implemented in 5 phases. So in first phases, we will do the preparatory study, like to interview the auxiliary ANM, this health workers and the person who involved in this administration of PEP drug. And then second part will be the exploratory study involving the health workers as well as the other medical officers in leprosy eradication program. And side by side, we also develop this an app development, and then we will do 1-year cluster randomized control trial. And after the randomized trial, we will do post-exposure assessment, and then we will scale up use-based study and results with dissemination of the programs for government officers and our national level and health workers. Next slide, please.
You have still half a minute in total.
So the expected outcomes, they analyze the barriers to implement the SDR PAP program through conventional method. Second, expected outcomes, assessment of mobile application that supports this PAP implementation program. Third, a comparative study of the advantage and disadvantage of PAP supported delivery versus conventional paper-based solutions. And the fourth outcome is a plan for scaling up the PAP delivery system supported by them. So as of now, our project status is that we have recruited the project staff, and we also done qualitative exploratory analysis, as well as background of districts and staffs involved in this PAP drug distribution. Also, we have translate that tools in local language. We also submitted for our ethical approval and the draft structure of the app development, insights of the SDR PAP program, and staff digital capacity assessed by the app development system. Thank you so much.
Thank you very much, Dr. Samarul Islam. Are there any questions for Dr. Islam?
There are no questions for Dr. Islam yet, but we have still 3 questions for the first presenter, Dr. Ephrem Mamo.
Then we'll proceed with those questions.
Okay, so we have one question, Dr. Ephrem, from Martin Nyoku. He is asking if the skin camp approach involves slit skin smears and if counseling was done in the field for positive contacts.
Thank you. And the skin camp approach is not doing slight skin smear. It is only by clinical diagnosis using of dermatologists rather than slight skin smear.
And was counseling done for positive cases?
For index patients or for example,
No, for new find positive contacts.
the newly diagnosed patient? Yeah, we will provide counseling. First, we provide information script, and then informed consent will be taken. Then we will provide counseling for referral, or for those diagnosed with leprosy will be counseled and referred and linked with health services.
Okay, thank you very much. And we have another question also for your presentation. It is coming from Ruth Budlin, and she's asking why you are not inviting neighbors also to the health center facilities, but only contacts, household contacts.
Yeah, the objective is, the assumption is for the skin camp approach is those neighbors and the household contacts, but for the health center based approach, we are only include the household contacts only, because our assumption is high number of new leprosy patients will be diagnosed from the household contacts, on average of from 1,000 up to 10 or 11 leprosy patients in the household. It is not only about inviting to the skin camp site or inviting to the INSEE. It is not our objective. Is not only to inviting to the facility level or to the skin camps. It is also based on the assumption that the health centers is only the household contact, which is high index, high leprosy diagnosis, and the community contact is gathering of 100.
Okay, thank you very much. And this brings us also to one comment which was sent in from Professor Jan Hendrik Ricardus. He is commenting that he just wants to point out that the number of new leprosy patients found through skin camps is high, but also the percentage wise is lower than from the health center facility approach. So that means in the health center facility approach, we are more effective in finding new cases. And this is very encouraging.
Yeah, this can be an answer for roots.
Yeah, this is an answer to root as well. Thank you.
Okay, shall we have one more try for Dr. Erika Sanga to join and do her presentation?
It's okay if I just explain how far we are, because we have not even started data collection. That's okay with you.
Yes, of course, Erika. We would be happy if you have 10 sentences maybe on the project to give us an update.
So for the leprosy antimicrobial study resistance, we have not yet started data collection, but the day before yesterday, I mean on 5th and 6th April, we had an investigators meeting, let's say a kick-off meeting where we had to discuss different logistics for the data collection team, since the study sites are scattered in different parts of Tanzania. So we had the data collection team, the regional leprosy coordinators, and the officials from the National TB and Leprosy Program. We are here this week. Actually, we finished the evening of Wednesday. So we have set off some logistical issues, and this delay was due to delay in training. I think Christa can help me explaining in this. That training was supposed to be done in January, so that in February we started data collection. But due to unavoidable circumstances, the consumable for laboratory training did not arrive on time. And by the time we had the consumable, the facilitator was unable to travel to Tanzania due to COVID restriction and the other conditions. So training has not been done. However, we agreed that we start data collection end of this month, April, and by the time the facilitator comes, she will use maybe the sample which we have already collected as part of training. So like everything is ready now for field work. We plan to have, we call it a visit study, a sort of mock run, one of the sites, because during discussion, we realized there's a lot of logistical challenges due to road infrastructures in some of the area where they cannot transport the sample within like 3 to 4 hours in the iceberg. So with ice packs, it was thought that in some areas it's hot. So for areas where we need to travel for like 80 hours, the sample might be compromised. And our lab manager has communicated with Charlotte, and she has given us some advice. So probably by end of April, data collection will start. I think that's all I can update from what I know.
Okay, thank you very much for this report that you have to improvise in this way, but still we're happy we heard from you and your project. Also want to thank Dr. Samarul Islam for his effort in presenting a very complex study in only 3 minutes. So thank you for that. It was done very nicely. We have some few more minutes to address any questions or remarks on any of the presenters.
Yeah, Joyce, I have one more question found from Peter Nichols, and he is asking for the work in Mozambique and Comoros. Has it been possible to assess the relationship between economic status and new case diagnosis?
We have collected information on housing structure. So we will have some very basic information, but yeah, I think by and large, these villages that are affected are poor villages, and I don't expect much to come out of this analysis. But we do have, we collect the information on at least the housing structure, and of course we have the
the coordinates of where the household is located. So it's something we can look into.
Okay, that's all from the
That's
question.
all from the questions for now. So then I try to complete this sharing with a remark that this was a very nice technical round of presentations, no problems. So I'm very proud of everybody who made this possible, and for everybody who cooperated in this, in order to get those people some rest until the next meeting where we meet each other all again. I'd like to finish this meeting thanking you all for your attention and your the very smart and good questions that were asked and the wonderful presentations. Thank you very much and see you at the general round.